Awesome. Everyone can see that okay?
Yeah.
That's
Yes.
good.
So yeah, thanks for having me. I'm glad that the bulk of you are here. It's really nice to see everyone on a snowy afternoon. I put my summer tires on yesterday, so that means we got 3 days of snow right after. I mean, it's bound to happen every year. So next year I'll do it a little bit earlier. But the focus of today's meeting will be to discuss some common medications that we use in the movement disorders clinic in treating our patients with Parkinson's disease, and to answer some questions around the use of those medications. We'll also talk about some potential new medications that may be coming to market soon, and then other medications, or sorry, other modes of medication delivery that aren't necessarily just by mouth. So yeah, feel free to jump in at any time or put questions in the chat. Emma will help moderate the chat a little bit. But yeah, let's get going. So like I said, we'll start off with a discussion around oral medications, some that act on dopamine and some that act on other chemicals in the brain.
I think that's the one you're on, right?
And then what we'll do is we'll also discuss other medication delivery options that are available in Canada. So this is just my one slide on what happens in Parkinson's disease, because I think it's really important to discuss. But essentially what happens is we lose cells in the brain that produce dopamine. And that's, the core crux of the disease. And we're not really sure why it happens, but we think it's because of a combination of various environmental factors or possibly some genetic factors, which is kind of outside the scope of today. But it's probably a combination of things that leads to people developing Parkinson's disease. But because it's the cells that produce dopamine that slowly die off, our treatment currently relies on modulating dopamine in the brain in some way. And so that'll kind of be the base of our discussions today. So we'll get right into it and talk about levodopa, because this is the medication that most people with Parkinson's disease are on. I think, I like to call it the most natural medicine that we possibly have in all of medicine, because it's exactly what our body makes. So what that means is you eat a steak or some form of protein, it gets broken down into proteins and then amino acids. And along those steps, all the way down, the last step is dopamine. The step before dopamine is actually levodopa. So it's exactly what your body makes, just in pill form. The problem is if you take pure levodopa, you'll throw up right away, because once levodopa is converted to dopamine in our blood, it makes us feel really, really nauseous. So we need the dopamine to get in our brain. And so what we do is we combine it with something called carbidopa or benserazide. And so levodopa carbidopa is a more common formulation that we prescribe. And what the carbidopa does is it prevents the breakdown of levodopa to dopamine in our blood. So the molecules can get up to the brain, levodopa can cross into the brain, but carbidopa can't. So we just pee out the carbidopa, levodopa gets into the brain, and then breaks down into dopamine where we need it, rather than just in our blood where we feel really, really nauseous. Levodopa benserazide is a different formulation of levodopa that we commonly use when people either, one, have a lot of nausea with regular levodopa carbidopa, two, have some drowsiness with levodopa carbidopa, or three, don't respond as we would have hoped. And then the hope is that a different formulation with a different chemical that prevents the breakdown of levodopa to dopamine in our blood perhaps make someone respond a little bit better. I think at our last visit in December, where we did one of these, we talked about the difference between IR, or immediate release, and controlled release, CR, levodopa carbidopa. So the immediate release formulation is generally what most people are taking through the day. And what that means is once it gets into our intestine, it gets broken down right away and absorbed right away. Whereas the CR formulation, the controlled release formulation, is thought to have a more delayed release, meaning it perhaps lasts longer than the traditional levodopa carbidopa IR formulation would. The challenge with that is the CR is a bit tricky in that we don't really know the dynamics of the medication all that well. Theoretically, you would expect a nice, steady, slow administration of the drug, and absorption of the drug, but sometimes it's erratic. Sometimes it doesn't get absorbed at all. Sometimes it's really fast. Sometimes it doesn't go in, and then 4 hours later it kicks in. And so I mentioned this last time, but we sometimes colloquially call it crappy release instead of controlled release, because it's unclear on on how effective it really is. And so most movement disorders physicians only use it at night rather than during the day. And the reason for that is if you're asleep, it doesn't matter if the release is in 1 hour or 3 hours or 4 hours, it still helps your morning time symptoms a little bit better. And if you're relying on it to work during the day, it's going to be erratic and it won't work as well as you would hope. So we tend to use the IR, the immediate release formulation during the day, and the controlled release formulation at bedtime, so the morning symptoms are a little bit better. So those are the differences between levodopa carbidopa and levodopa benserazide, and then the immediate release and the controlled release formulation. And so, yeah, important point here is that levodopa is very, very natural. It's exactly what our body makes, and we've kind of distilled that into a pill form, and then we get it where it needs to with these other kind of chemicals that we attach to it. Of course, despite being exactly what the body makes, there are side effects that come with levodopa. So these are the more common side effects: nausea, lightheadedness, sleepiness or drowsiness, dyskinesia, or those wiggly movements that people sometimes get, and sometimes, in some cases, hallucinations. And this is because, dopamine doesn't just act on the part of our brain that helps us move. It also does all kinds of other things in our brain. And unfortunately, we can't target levodopa directly into the movement parts of the brain. It kind of affects the whole brain, right? Which is why we get some of these other side effects. So these are the 5 most common side effects, and I'll kind of go through these one by one and talk about how we manage them in the clinic. And this is something you can talk to your physician about if you'd like. So nausea by far are the most common side effect with levodopa. And usually it comes on when people are trying the drug new or for the first time. And so this is why generally when we first start the med, we start really slowly, sometimes even at a half tablet a day. And then every week we increase it to by a half tablet until after 6 weeks, we're finally on 1 tablet 3 times a day. And that's to make sure that the body is able to tolerate it from a nausea standpoint. It's not just at the beginning of the disease that people experience nausea. And so there's other ways that we can kind of control the nausea that comes with it. One strategy is to take it with meals. And so you may have read online or heard from others that, you don't want to take levodopa with meals because it can interact with protein and limit absorption of levodopa. While that is true, it's only true for, it's true for a smaller percentage of patients than we initially thought. Around 25% of patients have a distinct interaction with high protein meals and levodopa. And so the absorption of levodopa is lower in that proportion of patients, but that's a vast majority of patients that don't have that absorption difficulty. That gets more challenging as the disease goes on, but early on, if you're experiencing nausea, or even later on, you can try taking it with some crackers or a light kind of meal to try and improve the nausea. Other strategies that we have are using pro-motility agents. So one agent is called domperidone. Some of you may have heard of that before. But it's a medication that's not available in the US, but it is available in Canada. It's very rare that happens. But it really helps with motility of the gut. And so if you take that with your levodopa, sometimes it helps just move things along. That inability of the stomach to move that sometimes comes with Parkinson's disease gets better. And then the nausea abates as well when you take your levodopa. So those are just a couple strategies that we use to try and treat nausea when it comes to the levodopa. Another potential option is actually taking separate carbidopa. So people take levodopa carbidopa, and that comes in that regular 100/25 milligram formulation. Sometimes people take an additional 25 milligrams of carbidopa to try and really prevent that breakdown of levodopa in the blood to improve the nausea as well. So just a few things that we can do from that standpoint. The second side effect that's common is lightheadedness. And this one's a bit tricky because it's not just the levodopa that can cause lightheadedness, but unfortunately, the Parkinson's disease can affect our autonomic nervous system. So the nervous system that controls things like our heart rate and blood pressure as well. So not only is the disease going to cause some lightheadedness when people stand up, but the medication will as well. So it's kind of like we're stuck a little bit, right? Generally, we like to use conservative strategies with this lightheadedness, meaning making sure people are well hydrated, making sure that we use things like compression stockings or binders around the abdomen to help fluid return to the heart, boosting our blood pressure a little bit. If those strategies don't work, other things to consider are things like dropping off blood pressure medication. So over time, people with Parkinson's disease may not need their blood pressure medications because the blood pressure slowly drops as a result of the disease itself. And so oftentimes we'll suggest working with your general practitioner to try and see if coming off some of these medications can help the lightheadedness. If that's not an option, or if you're not on any blood pressure medications, one other potential medication that can trigger this is in men specifically. For the prostate, people take something called Flomax or tamsulosin. That medicine can actually cause significant lightheadedness as well. So that's another potential medication to back off on. So rather than adding new medications in, sometimes it's actually helpful to back off on medications to improve these side effects. If all of those things don't work and we can't back off on any of these medications, then we certainly have other medications which we can add in, which I'll talk about later in the talk. But like I said, using conservative things like non-medicinal things like stockings or staying hydrated can really improve the lightheadedness that comes with levodopa. The sleepiness is a bit of a tricky one. So sometimes the dopamine can make us a little bit drowsy and a little bit sleepy. Sometimes switching from a levodopa carbidopa formulation to a levodopa benserazide formulation can be really helpful in that regard. Sometimes it's actually the carbidopa that causes the sleepiness. So instead of the 100/25 milligrams, you can take 100/10 milligram formulation. Or sometimes there's a 250/25 formulation that you can take. So it reduces the overall proportion of carbidopa, which sometimes causes the sleepiness for people. The fourth side effect is dyskinesias, and we'll get into that a little bit more as the talk goes on. But basically, the way to manage dyskinesias is kind of modulating the medications that you're on. So usually dyskinesias come on when dopamine hits its peak, and then it slowly gets better as it kind of wears off. And so the way to modulate dyskinesias or improve dyskinesias is to try and lower those peaks and valleys. And instead of big ups and downs, we kind of get more steady state delivery of dopamine. And like I said, we'll talk about that down the line. The last one is hallucinations. And so this is not a side effect that everyone experiences. Usually it's a manifestation in later stage Parkinson's disease, if people experience it at all. So again, not something that everyone with Parkinson's disease will get, but it can happen. And how they generally start is with what we call presence or passage hallucination. So sometimes people say, oh, like I thought I saw a bird fly by me and I look over there and it wasn't there. I thought I saw a rat or a cat run past me. I looked and it wasn't there. But it can then turn into well-formed hallucinations, such as like, oh, there's a cat in the corner of the room and I know it's not there, but it's still there in my eyes, right? So this is another tricky one where sometimes it's just the disease process that does this, but the dopamine can enhance this as well. So if you think about this conceptually, the disease, Parkinson's disease, is too little dopamine. A disease with too much dopamine can cause mental illness, right? So something like psychosis. And so if we're adding a ton of dopamine into the brain, sometimes you can manifest symptoms like that. And we'll talk about how we manage those symptoms down the line as well. So those are some of the more common levodopa side effects. But again, a very safe and effective medication. The rates of side effects in levodopa are around 10 to 15% for any one of these. Hallucinations significantly lower. The vast majority of people tolerate levodopa really, really well, and it still is our mainstay symptomatic therapy for Parkinson's. Beyond those side effects, so obviously if you're experiencing significant side effects that we just discussed, that's probably too much dopamine or levodopa. But is there otherwise such a thing as too much levodopa beyond just those side effects? So there's two things that I wanted to discuss. The first is something called dopamine dysregulation syndrome. So dopamine is our happy chemical. When we feel good, we get a rush of dopamine, as people know. And so sometimes what that leads to is a persistent desire to keep taking levodopa. And so people won't have any tremor, they won't have any stiffness or slowness, but there's just like a need to take levodopa, and this results in escalating doses. So sometimes this means people take over, 20 or 30 pills in a day, whereas they only really need like 8 to 10 pills in a day. And it's almost like an addiction that gets fed. And it's really important that if you're starting to notice you're taking escalating doses of levodopa at home on your own without the advice of your physician, that you talk to your physician about it, because we can intervene and change things around till we avoid those problems. One of the more rare side effects that we see is called punding. And this is a behavior that we see sometimes, again, only with really high doses of levodopa, and it's very, very rare, where people start arranging things randomly in the house. So it's not like you're organizing anything, but let's say you had a stack of paper clips or safety pins, you would kind of just move them around on a desk without any meaning or any purpose. And it can last like hours at a time. And so again, a rare side effect that comes on with too much dopamine on board, and we just slowly back off, and it gets better and goes away, in fact. So just a couple things to look out for. But again, both of these are really, really rare, occurring in less than 1% of the population. So, despite all the things we can do to try and manage some of those side effects or try and see benefit, you may just not see the benefit from levodopa, or the side effects may be intolerable. So what if you can't take levodopa? What are some other options to manage the motor symptoms? Well, if levodopa doesn't have a good effect, I think then it's important to talk to your physician about, just ensuring that the diagnosis of Parkinson's disease is correct, because that's one of our core things that we look for, is a good response to levodopa and making the diagnosis. It just may be that you're not able to tolerate a high enough dose because of side effects, and then we go to some other potential options. One of those options is what we call a dopamine agonist. And what an agonist is something that acts at the same receptor that dopamine does in the brain, but it's synthetically produced. So as we discussed, levodopa is what our body makes, but pramipexole and ropinirole are produced in the lab, and they're used to mimic dopamine. And they're a bit more potent at the dopamine receptors, meaning they bind a little bit better than what our body makes, which is kind of weird to think about. But they have different efficacies, meaning they work a bit differently, and they have different side effects. So from a motor symptom standpoint, meaning the hallmark features of Parkinson's, the stiffness, the slowness, and tremor, the dopamine agonists tend to work a little bit less, like a little bit worse than levodopa does. There still is a good effect, but they tend to not be as good as levodopa in treating those core features. The side effect profile is also slightly different. So there are, the same side effects that we saw with levodopa, so nausea, lightheadedness, dyskinesias, they can all occur with dopamine agonists, but there are a few other side effects that are important to point out here. The first one is what we call impulse control disorder. So that's something where, again, dopamine's our happy chemical, and this is a more potent chemical that's created, right? So it binds that receptor better. So we chase, for all intents and purposes, highs, right? So people have a hard time not performing addictive behaviors. And that can include things like eating like 3 bags of chips in a night, which sometimes I do. But anyway, just excessive sweets, excessive gambling, excessive shopping. Sometimes it can lead to hypersexual behaviors. And these are impulses that are just really hard to control. And it's not intrinsically who that person is. It's just the drug that's making people do this. The other side effect that's important to know about is something called a sleep attack. And this is where you're just kind of hanging out watching TV, or sometimes, and hopefully never this happens, but it has on some occasions, driving a car, and then all of a sudden you just fall asleep. And it can be really problematic, because if that happens, that means you can't drive for 3 months until you're off of these medications. Or once you're off of these medications, I should say. So it imposes a driving restriction. So it can be a bit tricky. And so essentially, because there are similar rates of dyskinesia we're seeing now, the risk of these sleep attacks, the risk of these impulse control disorders, and because it's less efficacious, in the movement disorders clinic, we're far more likely to use levodopa than a dopamine agonist as a first-line therapy. Sometimes we add in dopamine agonists if levodopa isn't working well enough. So sometimes people are on both. The other place that dopamine agonists have a good role is for restless leg syndrome. So sometimes that can come on in Parkinson's disease, where people feel really jittery in their legs and have a hard time sitting down in the evening and feel like they need to get up and start walking around all the time. Levodopa can treat that, but it actually can worsen the problem as well. Whereas pramipexole or ropinirole can treat that problem really, really nicely, even at a low dose. So that's another indication that we would use this in Parkinson's disease. Okay. Amantadine. This is a third different medication that we use in the clinic. And this medication we use for dyskinesias only. It used to be something that we used as first-line therapy because people thought maybe it gave them a little bit of an energy boost, or maybe it treated some of the other symptoms of Parkinson's disease. But we now know that this medication is best used for treating dyskinesias. So for example, let's say if someone is on 2 pills of levodopa 4 times a day or 3 times a day, and each time they take the medicine, about an hour in, they get really wiggly. If we try and back off to 1.5 pills 3 times a day, the motor benefit, the movement benefit just isn't there. What we'll do then is add amantadine 3 times a day. So the movement benefit is still there, but then the dyskinesia has settled down. And so that's the purpose of this med. The challenge with it is as the disease progresses, sometimes it can cause people's cognition to worsen and therefore cause hallucinations to worsen. So if you start developing hallucinations or start to develop some confusion or cognitive change, this is one of the first medications that you're on that we will back off on, because oftentimes we see benefit from it. So this is something to watch for if you start it, just to say, hey, look, my memory is maybe a bit worse than it was before this medicine. Do I really need to be on it? And a lot of people don't notice that, but some people do. So just keep an eye out for it. But it can be really effective for dyskinesias, right? So if you do need that motor boost and want to try and suppress the dyskinesias without backing off on levodopa, this medication is a good option. The other thing to look for is just a skin rash or some, we call it, our fancy word is livedo reticularis, but basically what that means is like a lacy rash on the legs that sometimes can lead to clotting issues. So if you start developing a weird rash on the legs, please let your physician know as well. So those are 3 options. What's the next one? Entacapone. People may have heard of this one before, but basically what it does is when dopamine is in our brain, it gets broken down. So when one nerve is kind of communicating with another nerve, dopamine kind of hangs out in between and sends a signal across the two, but then eventually gets broken down and goes away. What entacapone does is it prevents that breakdown. So it basically prolongs the life of dopamine or prolongs the life of levodopa. So for example, if someone was taking levodopa at 8 o'clock and their next dose was at noon, they say, oh man, by the time it's 11 o'clock, I notice that it slowly starts to wear off. You can add entacapone to your 8 o'clock dose, and it may extend the life all the way to noon when your next dose is being taken. So we really use this for wearing off between doses of levodopa. So it should be taken with each dose of levodopa or alternating doses or something like that. It shouldn't be taken independently without levodopa because there's nothing to extend the life of if you're not taking levodopa with it. Because all it does is extends the life of levodopa, the side effects are almost the exact same, except for one, and that's orange pee. You'll be surprised how many times we get a phone call about this. It's obviously very terrifying when your urine changes color like that, but please watch out for orange urine if you do take this medicine, and it's totally normal and nothing that you need to worry about. Another class of medicine is rasagiline or selegiline. These are either once a day or twice a day. So once a day is rasagiline, twice a day is selegiline. These medicines also prevent the breakdown of dopamine, but they just last a lot longer. So you don't need to take them with each dose of levodopa. The problem is they're really expensive in Canada, and they don't really work as well as entacapone does. So we are less likely to prescribe these because even through Blue Cross sometimes or other drug coverage agencies, we don't get the coverage we need, and it can cost like a couple $100 a month, which is not ideal when we have other medicines that work similarly or perhaps even better. So you may be on one of these, but these are some of the less commonly used medicines in the clinic. So I created this graph to kind of conceptualize what I've discussed so far. So going back to junior high math, we have dopamine on our y-axis, and then our doses of levodopa on our x-axis, okay? The bottom dotted line Can you see my mouse?
Mhm.
Okay, the bottom dotted line is the lower threshold of dopamine you need in your brain to feel normal. The upper dotted line is too much dopamine. So in the context of Parkinson's disease, we start here. We start below that dotted line because we have too little dopamine in our brain. And then we go to our first dose of levodopa of the day, and then boom, we cross that threshold and we feel good, and then it hits its peak and then slowly starts to wear off. But before we go below that line again, we take our second dose and it goes up, comes down, and we take our third dose before it wears off and it comes down, and then we get this up and down. But early on in the disease, what happens is we stay within that threshold. So we stay within that threshold of feeling normal, and we don't have too much dopamine on board. What happens, though, as the disease progresses, is that window narrows. So now what happens is we start below the line, and then it takes 20 or 30 minutes for the medicine to kick in. And then we feel good, and then, oh, we got too much dopamine, so we start getting dyskinesias or lightheaded or the wiggles. And then it slowly starts to wear off, and we feel better. And then, oh, before our next dose, we actually start wearing off, and we get below that line for about 20 or 30 minutes. We take our next dose again, and then it takes another 20 or 30 minutes to kick in. So we have an hour of feeling like our symptoms are really bad here. Then we feel good again, and then there's too much dopamine, and then we feel good again, and then we wear off, and then it takes some time for our meds to kick in. And this is that classic on and off pattern of motor fluctuations that we see in Parkinson's disease. So people describe on symptoms, so feeling good, not having as much stiffness, soreness, or tremor, and off, where they have stiffness, soreness, and tremor. And this is how that cycle works as the disease progresses. It's that dopamine window that really narrows. And so it takes some time for drugs to kick in, and then sometimes it's a bit too much, so we get dyskinesias, and then they wear off before our next dose. So what happens is we try and use medicines to try and make this line as flat as possible, try and stay within this window. So how can we do that? Well, for example, if we were to make doses more frequent, what we could then do is reduce the total dose. So let's say we took a pill in between all these dotted lines, or all these kind of dose markings here, right? So what then happened is, okay, sure, it takes some time to go kick in, but we don't take as much, it starts wearing off, but then we take the next dose, then we take the next dose, then we take the next dose, then we take the next dose. So more frequent but less levodopa can sometimes keep the line nice and steady. What else can happen is, to try and prevent this wearing off, we add entacapone. So now you start taking your levodopa, it kicks in, this peak lasts a little bit longer. So by the time it wears off, you take your next dose, and then the peak lasts a little bit longer, and then you take your next dose. How does amantadine work? Well, amantadine takes this line and bumps it back up here. So it won't change your off time, but it will remove these peaks of feeling like you have too much dopamine. So your wiggles, your dyskinesias will go away. So all these medicines basically work on dopamine to try and create as flat of a line as possible within that window of too little and too much dopamine, if that makes sense. So these are all questions and things to talk about with your physician, but that conceptualizes kind of why we have all these medicines and how we try and use them in different ways to try and keep people feeling good for as long as possible. Okay. These are some of the other commonly prescribed oral medications that don't act on dopamine, okay? So all the other medicines we talked about act on dopamine in one way or another. And these medicines act to treat different symptoms that come with Parkinson's disease. So the first category here is quetiapine and clozapine. These medications we use for hallucinations sometimes. And I included them because they're not discussed commonly, because sometimes we're afraid to talk about hallucinations in Parkinson's disease, but it's important to know what they do and why we're careful with them. So as I discussed, hallucinations can be because of too much dopamine in the brain. And that can be because of too much levodopa, or it can be because the brain is just used to less dopamine in the brain because of the Parkinson's disease, and then you try and add in a normal amount of dopamine, but then you develop hallucinations. So what these two medicines do, quetiapine and clozapine, is actually they block dopamine. So they block dopamine to prevent hallucinations. And there are many, many medications out there that block dopamine. And you might be thinking, well, that's a silly thing to do. We need dopamine in Parkinson's disease. These two medications tend to have the least effect on the movement symptoms of Parkinson's. So they're the least likely to cause worsening of tremor, stiffness, and slowness when we're in the category of all those other dopamine blocking medicines. So that's why we tend to use these two to try and assist in treating hallucinations. But there's still a risk that they can do that. So the first thing that we do is we use the next category of medicines. These medicines are called rivastigmine, donepezil, and galantamine, and they don't block dopamine, but what they do is they act on another chemical called acetylcholine. That chemical, if we have reduced levels in our brains, sometimes we can see in Alzheimer's disease. But what these medicines do is they can actually help prevent hallucinations without blocking dopamine. So it's kind of a two birds, one stone thing. You get rid of the hallucinations and you don't have to worry about your movement symptoms worsening. So oftentimes we'll try using these. The added benefit is a side effect is often looser stools, so it can help with constipation as well. The third category of medicines here goes back to one of those other side effects we were talking about, which is lightheadedness. So lightheadedness, again, can come from either the disease or from the medicine themselves. And if you can't back off on some of the blood pressure meds or some of those prostate meds, these are the medicines that we tend to use for the lightheadedness. So the first one that we sometimes try is called pyridostigmine. And the reason why we use this first is because sometimes people with high blood pressure, when they take the other ones, when they lie down at night, their blood pressure can really skyrocket, like into the 200s. The main problem that people with Parkinson's experience is when they stand up, they get really lightheaded and feel like they're going to faint, right? So we want the medicines to work when people are standing up, not when they're sleeping at night. And pyridostigmine, this third one here, it doesn't cause that jump in blood pressure at nighttime. And again, a common side effect of it is actually looser stools, so it can help with constipation as well. Oftentimes, though, it's just not strong enough. So we have to use one of these other two medicines, which actually boosts the blood pressure during the day. We recommend you take them earlier in the day. So when you lay down at night to sleep, the blood pressure doesn't go up. But this is a risk with these other two medicines. The last medicine here is called mirabegron, and this is a medication that we use for bladder symptoms. So sometimes people with Parkinson's disease can have urgency, frequency of urination, meaning they're peeing all the time. Urgency meaning when they gotta go really, really fast and like right away. Otherwise, they're worried about losing control. And then, of course, incontinence can sometimes happen as well. There's a vast selection of bladder medications we can use. But unfortunately, a lot of them block that chemical that we just talked about, acetylcholine. And understandably, if you're blocking that chemical acetylcholine, sometimes it can lead to cognitive change. Mirabegron is the only bladder medicine out there that prevents the frequency, urgency, and incontinence of urination that does not act on acetylcholine. So there's no risk of cognitive impairment with mirabegron, whereas there is with other drugs like tolterodine or sulfenacin, Vesicare, those types of medicines all can potentially cause cognitive change in Parkinson's disease. So for the urinary symptoms, this is our first medicine of choice. So those are all the oral medicines that are out there. What about some other medications of drug delivery? So one option that's out there right now is called the rotigotine patch. And basically what it is it's a patch that you put on your skin, and it releases dopamine agonists, so like a synthetic dopamine like pramipexole or apinarol. It releases it in steady state under the skin. So this is a way to avoid those big ups and downs that we saw on that graph, because you're not taking it by mouth, so there's no pulse. It just sits on the skin and over 24 hours delivers medication nice and steadily under the skin. So you have less ups and downs because of that. The thought then is perhaps there are fewer side effects because you don't have the pulse. Because it's steady state, perhaps it's the pulse that causes the lightheadedness, hallucinations, dyskinesias, sleep attacks, impulse control issues. So theoretically, there's a slightly lower risk of side effects with the patch. The other benefit of this is it avoids metabolism through the gut. So you don't get as much nausea because you don't take it by mouth. It doesn't have to compete with other chemicals for absorption. It doesn't go through the liver first before it goes into your blood system. So it acts more quickly and gets into the system. It's more available to act in your body. So it avoids the gut, which is nice. The issues are it can be expensive. So we do have coverage through Blue Cross generally for it. But if you don't have Blue Cross, it can be pretty pricey. Even with Blue Cross, sometimes people do have to pay a little bit out of pocket. And the other issue is sometimes people can develop rashes. The patch can fall off and it can be a bit irritating in that sense. So something to keep in mind. But it is a nice option for steady state, kind of more flat drug delivery. This one's been out there for a while, but levodopa carbidopa intestinal gel. This is steady delivery of drug into the small intestine. A bit more invasive because it does require a tube to be put in. And that tube requires management long-term, right? So it needs to be kept clean. And you need to look for any abnormal secretions. It also requires you to store the drug in the fridge and then kind of manipulate and put in capsules or put in canisters. But what is really nice about it is, again, it is nice steady state drug delivery. You don't get the ups and downs. You run at a steady rate over the day to try and stay within that nice window that we talked about before. It runs during the day, but not overnight. So that means if you do need have symptoms in the morning, sometimes people do take long-acting, the CR formulation of levodopa at bedtime. But again, that smooth symptom management is what's really, really nice about it. This formulation came out 6 weeks ago. It's finally approved. Everything got approved in Canada. It's phoslevodopa, phoscarbidopa, and it goes under the skin. So this is awesome because it took forever. It took like 30 years for us to figure out how to dissolve levodopa. And now that we can do that, it's in a liquid form that goes under the skin and gets absorbed around the abdomen. You don't require a tube insertion for this. Again, it's steady state delivery to try and stay within that window. Again, you avoid gut metabolism, so it doesn't go into the intestine. So you don't need to worry about competing with proteins. You don't need to worry about going through the liver. There's less nausea associated with it. The nice part is it also runs during the day and at night. So you can run a nice steady state during the day and then lower it a little bit at night because you're not moving as much. So when you wake up in the morning, you feel well. But what's important is if you wake up at night to pee, you also have some levodopa on board, so you're not frozen and stuck when you're trying to go to the bathroom. As is with any medication, it's currently only approved through private coverage, so things like Manulife, Sun Life, Canada Life, etc. But we're hoping by end of year or early next year, it'll be approved through Blue Cross publicly as well. So something to keep an eye out for and to ask your physician about, because it's one of those nice options that we have that keeps us within that window with steady delivery. The main side effects here are all skin related, right? Because it needs to go under the skin. So sometimes people develop rashes, sometimes people develop skin infections, sometimes little nodules develop, which people don't like cosmetically. So these are the main side effects to look for. But again, a nice steady drug delivery, which is a way to avoid those big ups and downs that we see with pills. These are a few medications that are not available in Canada. One of them is called Rytary. So I used to use this in practice when I was in the US. It's basically a slightly better version of CR levodopa. So it has an immediate release, a medium release, and a long release capsule that slowly get dissolved in the stomach. And so it kind of lasts a little bit longer. You get a pulse and it lasts a little bit longer. I have to say the benefit was not as great as I thought it would be. So I'm not super jealous that we don't have it here. The second medicine is called istradefylline. I won't say the brand name, but that's okay. That's the generic name. And so what it does is it actually works on caffeine receptors. So you're probably like, oh man, I should just have a bunch of coffee and maybe my Parkinson's will get better. But it acts on a very specific caffeine receptor that modulates dopamine. And if you drink a coffee as a whole, it kind of weighs, there's like a balance of good effects and bad effects. So coffee in general doesn't help, but when this medication is added to levodopa, sometimes we reduce those fluctuations a little bit, those offs, those kind of wear-offs get a little bit better. The problem is we do see a lot more dyskinesias with this medicine, or we did anyway when I was practicing in the US. So again, not super jealous that we don't have it in Canada. The last one is the levodopa inhalation. And it's for those sudden off periods or those wearing off periods, and people would just inhale some levodopa, and then the theory was that would carry them over to their next dose. The challenge is this is a powder, and when people would inhale it, it would cause like significant coughing fits because the powder would get stuck to the back of your throat, and it would just be really hard to get out and get absorbed. And so oftentimes people would start it, but then just come off of it because it was just so irritating. So again, I think, all the medicines that have shown benefit that don't have side effects that are intolerable, I think we have here, but these may be some that you see on some message boards and things like that. And to be honest, I'm not super upset that they're not here yet. And then I just wanted to talk about a few quick future directions before we open up the floor for questions. I want to leave lots of time for questions. But these are some clinical trials that are ongoing worldwide. The first one is looking at GLP-1 agonists. So these are things like exenatide, or the more famous one is Ozempic, but there's no trial for Ozempic in Parkinson's disease. It seems kind of weird, right? Everyone's like, oh my gosh, like, why are we using Ozempic or things like that in Parkinson's disease? But essentially what these GLP-1 drugs are doing is they're helping with cleanup of breakdown products of cell death in our brain. And what we know is those products, if they're present in our brain, they can kind of perpetuate the cycle of cell death. And if we clean them up quickly, we hope that there may be some reduction in the speed of progression of Parkinson's disease. So we're looking at this as a potential disease modifying, not just symptomatic treatment in Parkinson's disease. There's some early trials that show maybe some benefit, but the bigger trials are about to get started in the UK. There's none in North America at this time. Another trial that's ongoing in the UK is Ambroxol. This is an old cough suppressant medication that is thought to act on a protein called GBA. You may have read that GBA mutations in people's DNA can increase one's risk of developing Parkinson's disease. And so Ambroxol acts on that protein. And again, it's being investigated as a potential agent to slow down progression of Parkinson's disease. The phase 3 trial, again, is going on in the UK, but not in North America. The one trial that is going on here in Calgary is the LUMA trial. So there's another protein called LRRK2 or LRRK2. That protein also, if there's a mutation in it, indicates that there's a higher risk of Parkinson's disease in that population if they have that mutation. And largely it's in the Ashkenazi Jewish population that we see that that mutation occurring. And so this medicine that we're using is a medicine that kind of acts on that protein and modulates it a little bit to try and slow down the progression of Parkinson's disease as well. The trial currently is only for people who are not on levodopa or not on any other Parkinson's meds, but the hope is that down the line it'll open up to other people as well. So these are just some of the other oral medications that are out there that are being investigated but are not approved. The ones that are approved right now, as we talked about, are mostly either acting on dopamine in some way, because that's what kind of happens in Parkinson's disease is the loss of dopamine, or they're used to treat some of the other symptoms that we see, or even some of the side effects that we see from the medications in Parkinson's disease. So those are things like urinary symptoms or lightheadedness or hallucinations or things like that. So that was a very quick overview. I don't have any other slides, but I just wanted to run through things that we use in the clinic. I think we got some time for questions here, so maybe we'll open up the floor, and I'm happy to take any questions.
Okay, there's one question about the patch. Is it waterproof?
It's a great question. We recommend covering it when you take a shower or go swimming, like with a bandage or something like that, to help prevent it from falling off. So I guess waterproof, no. Water resistant, possibly.
Okay. Something I heard from a client was they purchased on Amazon. It's called Second Skin. They usually use it for tattooing, but then it's pretty easy to just cover and make more waterproof. Yeah. That was the only question in the chat, so I'll give folks a minute or two to type or unmute if they have questions. Bobby, there you go. Yeah, go ahead.
Yes, for the subcutaneous option, can you wear it all the time? Can you go swimming? Is there Is it a small needle that pierces your skin to deliver the medication, or how does it work?
That's exactly what it is. So basically, it's you kind of have like a little fanny pack, like I would say is like this big, and it kind of sits on your belt. And then there's like a little motor that runs with a small needle that just goes under the skin that gets covered. So again, you would need to take that patch with you, that pack with you if you're going to go swimming, which is a bit tough. So most people who go swimming just remove it, take some oral levodopa, go for their swim, come back, and then put it back on. It needs to be replaced every 24 hours, or up to 72 hours if you want to leave it that long. So some people just time their switch around the time they take a shower or go for a swim or whatever. So you can wear it across your chest, you can wear it on your belt. It's about the size of a large iPhone, I would say.
And you said it's covered presently by, like I'm insured by Canada Life, they would cover it?
Yep, they should. So private insurance is all that's available right now. So yeah, you should definitely talk to your physician about it if you have private coverage.
Thank you.
Okay, any other questions? No?
Great.
Dr. Karnik covered it all. You don't have any questions?
One last one, if I may.
Please.
Yeah.
Is this right now? All the drugs are for the management of the disease, or the slowing down of the disease, management in one way or the other. Is there any sort of studies for actually curing the disease or preventing it from beginning in the first place?
Totally. So those last three drugs that I mentioned there, all are looking at slowing down progression of the disease or stopping it, right? So that's good that we have those trials ongoing. The challenge is so as you know, or may not know, I guess, we did some clinical trials, including here in Calgary, looking at some of these alpha-synuclein targeting medications, right? So alpha-synuclein is the protein that we see in people's brains when they have Parkinson's disease. And so the thought is that if we remove that protein, or the thought was if we remove that protein, perhaps we could slow down or stop progression of the disease. And so what we saw is when people were given these medicines, we were successful in removing the protein, but we didn't see any convincing data that the disease was actually slowing down. So then the thought was, okay, like, maybe we're giving it to people too late. So maybe we need to do this early on before symptoms manifest, because what then happens is, as I said, we have products of cell death, and it just kind of propagates the cycle no matter what we do, even if we remove that protein. And so now what we're doing is looking at biomarkers, meaning sometimes people with vivid dreams in their sleep, they can have those 20, 30 years before they develop Parkinson's. We're looking at different ways of amplifying alpha-synuclein from the skin, and looking at this in people that don't have stiffness, slowness, or tremor. And then we're taking those people and enrolling people in clinical trials to see if we can prevent the onset of Parkinson's disease. And if they do develop Parkinson's, then hopefully slow down progression. So it can be sometimes a timing thing. It can sometimes be a patient selection thing, but certainly we are looking at various ways to stop or slow down progression. We just had a bit of a setback when we tried to use one of these medicines, right? And it didn't do much. But now we're looking at, maybe we just gave it in the wrong way, right? So there are projects that people are working on, both in terms of targeting alpha-synuclein and in terms of using other methods, like I said, with the GBA protein, the LRRK2 protein, and preventing or removing products of cell death as well.
Could you speak a little bit about the deep brain stimulation?
Sure. So not a medicine, but definitely something that people can consider to try and smooth out the ups and downs, right? So I like to think of deep brain stimulation as electrical medication. So what that means is, again, it's not disease modifying, but it's one way to steady things out. So the process is a long one, because obviously a brain surgery is not something we take lightly, but You'll go through a meeting with your physician. You'll meet with a DBS physician in Calgary, who is Dr. Aquino. You'll meet with the surgeons. You'll go through cognitive testing because a risk of the surgery is worsening cognition. So if there's already a deficit in cognition, you may not be a candidate for the surgery. Generally see one of our psychiatrists as well. But once all that gets approved, the electrodes get put in one of two regions in the brain. Certain regions are better for targeting people who want to back off on some of their medicines. Other regions are better for people with really bad dyskinesias or posturing or cramping, like dystonia. And then what happens is over the course of 6 months after the surgery, you kind of program the settings such that you reach a threshold where the symptoms kind of flatten out a little bit. And then you can potentially back off on some medicine to prevent those ups and downs, because the electrical medication in the background smooth things out a little bit.
And is it like any brain surgery? I imagine it would be dangerous to some degree.
There's a risk.
I saw on TV a CBC reporter who had Parkinson's, and when he turned off, he could turn off the machine with his cell phone, and his arm would wave like a windmill. But when he put it back on, the arm would become tremor free.
There is a risk of surgery, right? But ultimately, that's a risk a lot of people are willing to take, because the symptoms can be really, really devastating when they're up and down like that. We were the busiest center in North America when I was in Boston. We did probably 9-10 of these a month. And I have to say that like the benefit was remarkable. Like I'll be vulnerable. I cried a few times seeing how well people did. Just because they would have tremor for 15-20 years, and within seconds I could get rid of it, right? Like it was crazy. Not for everybody, but a really nice option for a certain demographic of people with Parkinson's.
If I can ask one last question, is there a certain age limit?
Sorry, say that again.
Is there an age limit for when one can be a candidate or excluded as a candidate?
Generally above 70, we worry about cognitive impairment post-op. So I don't know that there's a hard limit, but generally people above 70, we've seen poor cognitive outcomes.
I'm 69, so I guess I'm out of luck.
Good. I see there's some other questions. Evelyn had her hand up for a while. Maybe we'll go there.
Yeah, Evelyn, do you want to go ahead?
Dr. Karnik, I'm fairly new with my Parkinson's.
Okay.
I've been on Levocorb for probably about 2 years now, and I have a very erratic schedule.
Okay.
Is it really important that every day I take my meds at the same time, or is it more important that every day I take my meds at the same interval?
That's a really great question. And I would say the answer to your question is the latter. The interval is the most important because it really helps guide us, right? So for example, if I know that every time you take your meds, it lasts 3 hours and it doesn't get you to that 4 hours, that then helps me in deciding what I need to do with your medications at our next clinic visit, right? So I say, oh, like that 4-hour interval is too long. Maybe we need to reduce it to 3 hours, or maybe I add something that prolongs the life or whatever, right? Like I'm not going to be so strict that I say, Evelyn, you got to get up at 7 o'clock every single morning. I get it. People want to sleep in or do different things, right? But the interval really helps us sort out what we can do with your meds.
That's great. Thank you very much. I appreciate that.
Yeah.
Liz, do you have a question?
Yes, I just wondered, thanks for, first of all, about those graphs, because that's exactly what's happening to me. I was just wondering if you're on something like amantadine, how can you come off of that? Like I have an appointment next week with my doctor, and I just want to discuss it with them.
Yeah, so you can I would just generally taper it. I wouldn't stop it right away because you might a bit of a crash in your symptoms. But my recommendation generally is like if you're on 100 milligrams 3 times a day, I say go down to twice a day for a week, then once a day for a week, then stop it.
Okay, good. Thank you.
All right, there's one from the chat here from someone who is supporting a person with special needs and essential tremor and Parkinson's. They're mostly verbal with a few, or sorry, mostly nonverbal with a few sentences. And to observe changes, they're looking at walking, ability to do tasks. What are some other things that they could look for someone who's not able to verbalize how they're feeling?
Yeah, I think that's a really yeah, thanks for what you do. That's a really tough scenario. And I think what you can look for is a few things, right? So vocalizations in terms of speech power or strength, like if the volume of speech is low, if facial expressions are getting more blunted, physically, if the posture is stooping over a little bit more, if it takes longer to do things day to day, if potentially are they able to walk? Yeah, the gait changes are occurring, like slowing down, feet are sticking to the ground, unable to lift the feet up as well. Just, you know, I mean, ultimately there's a ton of things that you can be looking for. Those are all physical things, right? There's also non-physical things or non-motor things that I think are important, right? So if they're having to go to the bathroom a lot more frequently, that's something we can intervene on. If a change in position going from sitting to standing results in a sense of imbalance or sweating, it may be an indication that they're feeling lightheaded and they may be close to passing out. That's something that we can intervene on. So I would say, you know, it's never a bad question to ask your doctor, is this related to my Parkinson's disease? Because there is a chance it could be, and we know how to treat it, right? So, you know, and if it's not, whatever, we say it's not, right? Like it may be due to arthritic pain in the back or knee or whatever. But I do think that, you know, we often miss symptoms that we just don't think are related, but they often can be. So I don't know. There's a ton of things I could say, I guess, but I think it's worthwhile just having that discussion when you notice something that's new. And then there's a question about CBD that came shortly after that. This is a great question. I get asked all the time, and I guess the politically correct answer would be, I don't know. And that's the correct answer, I guess, which is we just don't know because there's no randomized controlled clinical trials that show either benefit. And importantly, there's no trials that show harm either. Anecdotally, people tell me that maybe it helps them sleep at night. Maybe it helps with the tremor sometimes. But again, there are people out there that have noticed some cognitive changes or sleepiness that comes with that as well. So keep in mind that anytime you take something in your body, there's a chance that it does good. There's also a chance it does harm. And that's why we do trials. And unfortunately, there aren't any on CBD. I would say that if it's CBD only, the risk is lower than if you have THC in it as well. So another thing to keep in mind. So as long as you know that there are risks, it's okay to try it and see if it helps you, because ultimately that's what we want to do, is make you feel better. So.
All right, thank you. And the last one is about probiotics.
Yeah, so there are definitely there are trials that are ongoing right now, especially because of the whole gut-brain thought process behind the pathophysiology of Parkinson's disease. There are some strains that are thought to potentially be better than others, but they're not 100% proven yet. So I recommend taking probiotics. I think it's totally fine, at least to help with you know, constipation or things like that. Anyway, can be helpful. Fiber supplementation really important as well. Staying well hydrated. In terms of disease modification, not that we know of.
Okay, thank you. So it's 2:30, so we'll wrap up here. Thanks, Dr. Karnik, for coming and taking the time to share your knowledge and all the questions that we got today. And our next webinar is scheduled for next month. It's a Q&A if you'd like to join, or you can check out the recordings online.